Okay, so trauma arrest management. Why are we talking about trauma arrest, and why do we even need a specific trauma arrest protocol? A lot of places don't have a trauma arrest protocol because it's kind of doing ACLS and, treating the H's and T's and, treating the other things that we've already talked about and that we already know about. Well, we do need specific trauma arrest protocol because treating traumatic cardiac arrest is pretty different than treating cardiac arrest from a medical cause, and a lot of time we're pretty nihilistic when it comes to treating patients in cardiac arrest from trauma because we think that nobody survives. And we used to think the same thing about medical cardiac arrest, but the fact of the matter is that there are survivors. There are survivors, and when you look at the overall survival rate, depending on the kind of trauma, specifically penetrating trauma, the survival rates are similar to the survival rates that we see from all comers in medical cardiac arrest. And in fact, if you can get there soon, so imagine a situation where you're working an event standby for a high risk activity like motorcycle racing or something, or NASCAR racing or something like that. Even if they die from blunt trauma arrest and you are on top of them seconds after it occurs, then their survival rates could be in the 50s. And that's pretty amazing to think of, that, just logistically, logistics can play a major role in trauma arrest survival and in all cardiac arrest survival. But of course, there are certain patients that we shouldn't even attempt on. So who should we not begin resuscitation on? Well, in most cases, if the patient has obvious signs of death, rigor mortis, lividity, things like that, of course you don't begin resuscitation. But this is not a large subset of trauma patients that we're going to be concerned about anyway. And of course, if they have injuries incompatible with life, you don't begin resuscitation on. What are injuries incompatible with life? Well, you all should know this by now. It's decapitation, so head cut off, incineration, burned beyond all recognition, and hemicorpectomy. Basically, the lower half of their body is completely severed. But there could be situations in which the patient doesn't have full decapitation, like they didn't put them in a guillotine or something like that and actually cut their head off, but maybe they have an open skull fracture and the brain's hanging out. I think that you could likely argue that is an injury that's incompatible with life. We recently had a situation where one of our crews had resuscitated or attempted resuscitation on a patient that had blunt multi-system trauma, and there was brain matter on the scene. It was dark, it was a poorly lit area, and it was difficult to see exactly how much brain matter had been exposed. But one could make the argument that that is decapitation. Conversely, just because someone has a gunshot wound to the head does not mean that that injury is incompatible with life. There are no absolutes when we're talking about this, and it does require good clinical gestalt and good judgment and decision making. And if you're ever in doubt, call med control. In the one case that I was talking about, med control told them to transport the patient. And that was probably not the right order for them to give. And after I followed up with UK about this patient, they said that it was probably not appropriate, and they agreed that if we're talking to a senior resident, you can ask to speak to someone else. You can ask to speak to an attending. Now, for the purposes of this protocol, these are the patients we're not going to begin resuscitation on. All others, we should. That doesn't mean we have to transport. You can still terminate. But we're going to, hopefully I can make it clearer for you who you should transport and who you should not transport. So, when we're treating a patient in trauma arrest, what are our priorities? Well, is it high performance CPR? Is it early defibrillation? Is it getting access? Well, unfortunately, we think of we put all cardiac arrests under the same umbrella, but they're not. And trauma arrest is not the same as medical arrest. And it would be hard to significantly deviate from the standard, i.e. The AHA, ACLS, BLS, CPR, that we have been taught for so many years. But the algorithms that we use for medical arrest are not appropriate and will not work for the trauma arrest patient. So we need an entirely different approach and an entirely different algorithm. Because if you're looking to save a patient from traumatic arrest and you do things the same way we've always done them, it just won't work. So why won't it work? Well, generally patients that die from exsanguination from trauma arrest, they generally progressively go into shock until you get pulseless electrical activity, possibly some other arrhythmia, VFib, VTAC, and then asystole. But imagine that you have a patient in trauma arrest presenting in PEA, or pulseless electrical activity, which is a frequent presenting rhythm for patients in trauma arrest. Does that person have a pulse? Well, no. Right? We called it pulseless electrical activity. But all that really means is that we can't feel a pulse. In fact, their heart could be beating, but it could just be that they're in such severe shock that we can't feel a pulse. And if we correct whatever it is that's causing them to be in severe shock, whether it's hemorrhagic, hypovolemic, obstructive, and so forth, then we can restore perfusion and regain pulses. So we don't know initially if the heart's beating or if it's not beating. And in traumatic cardiac arrest, we're generally going to assume that if they are in PEA, if they have organized electrical activity on the monitor, that they are in pseudo-PEA, meaning the heart's beating, we just can't feel a pulse. So then the question comes up of whether or not we should perform CPR. If we're going to presume that the heart's beating, should I or should I not perform CPR? Well, I think that there are two situations in which it is appropriate to perform CPR in traumatic arrest. And one is if it doesn't appear to be a traumatic cause of the arrest. So imagine that it was a low-speed MVC and there's no quickly identifiable trauma to the patient. It doesn't appear to be a traumatic mechanism. Then, perform resuscitation as usual. Or if the patient was driving erratically, swerving, it appears that they were having a medical event that caused the accident, then CPR as usual. Or if you have plenty of people on scene and you can assign someone to do CPR, then CPR as usual. But the main paradigm shift that we're doing is to not prioritize CPR. Does a good CPR fraction, perfect rate, perfect depth, minimal interruptions, do those matter in trauma arrest? We don't think that they do. And we think that they could possibly cause harm and get in the way of us efficiently and effectively performing the interventions that do matter. So do we have data on this? We have a little bit. We have some, observational studies. We have some animal studies. And we have a lot of expert consensus, and most of the expert consensus points to CPR not being a benefit or causing harm. Now, this was a very interesting study where they basically induced hemorrhagic cardiac arrest in pigs. So they bled them out. And then they provided these various interventions. So they had 5 different groups, one with continuous compressions, one with blood only, one with saline only. The 4th group had whole blood plus continuous CPR, and the last group had saline plus continuous CPR. So what do you think the outcomes were? Take a second. Who do you think had the highest survival rate? Well, we would probably think that whole blood plus continuous CPR, right? Well, that's not right. It was number 2. Group 2 had the highest survival rate, which was whole blood and no CPR. Who had the second highest survival rate? Well, that was Group 4, which was whole blood and continuous chest compressions. And I think anytime you insert whole blood into the mix when you're talking about traumatic arrest, that's going to have the best outcome. And then Group 3, which is particularly interesting, which was saline only, had higher survival rates than those that got saline plus chest compressions or those that got chest compressions only. So for whatever reason, restoring volume to the patient when they're bleeding out has better survival rates than trying to restore volume with saline and do CPR. So both got saline, both Group 3 and Group 5 both got saline. The major difference is Group 5 was also provided chest compressions, and they had worse outcomes. So anytime I see something like this, I ask why. How does this make sense? Because if we can't feel a pulse and we're unsure if their heart is beating or not, why is it? What is it about chest compressions that cause harm? And I think normally when we're talking about providing CPR on patients, there are 2 mechanisms in which CPR is effective. And both of these mechanisms require the patient to have an intact, unobstructed circulatory system. And it also requires the patient to have an intact thoracic cavity, because the 2 mechanisms are the thoracic pump and the cardiac pump. So we're probably familiar with the cardiac pump, which is where you compress on the sternum and it squeezes the heart between the sternum and the spine, and that pressure ejects blood from the heart. The other mechanism is the thoracic pump, which means that when we perform CPR, we're not just compressing the heart, we're compressing the entire thoracic cavity. We're changing the pressure within the chest, and that pressure change facilitates blood flow not just through the heart but also the major vessels and all of the vessels included in the thoracic cavity. But I have a list of reasons that CPR might be bad in trauma. 1, CPR interferes with resuscitation momentum. There's a heavy cognitive load in traumatic cardiac arrest. Not only are we trying to stop bleeding, decompress bilaterally, straighten long bones, apply pelvic binder, manage airway, but we're also trying to perform quality CPR. And when you're doing that, something is going to suffer. Something is not going to be performed as well as it could be if that was the only thing that you were doing. CPR makes ventilations more difficult. We talked about impact apnea. Ventilations are important in regular cardiac arrest, and they're also important in traumatic cardiac arrest. If that patient went into arrest because their airway was not positioned appropriately, or they had impact apnea, then early effective ventilations could be life-saving for that patient. CPR gets in the way of needle decompression. It's just hard to do quickly. It's hard to do quickly. Cardiac filling in CPR is less effective than administering volume. So think about that for a minute. The fraction of blood that we eject with manual CPR is not effective or is less effective than just giving them fluid boluses, which in effect provides an increase in preload, sends more fluid and blood back to the heart, and if that patient is in pseudo-PEA, meaning their heart is beating, we just can't feel a pulse, then their cardiac output will increase. CPR also makes thoracic injuries worse, meaning that if they do have damage to some of the structures in the thoracic cavity, we can make it worse. And there is a risk to us if we're compressing on the chest, and we could get poked by a bone or something else. Also, it just doesn't make sense to do CPR on a patient when that CPR is not going to be beneficial. Imagine the patient has a tension pneumothorax. Blood cannot get back to the heart because of that tension pneumothorax. And if that was the reason that they went into cardiac arrest, well, clearly CPR isn't going to add anything unless we decompress first. And if the patient died from hypovolemic shock, well, CPR isn't going to do anything unless we restore volume. But then it begs the question of, okay, you're talking about PEA, Floyd. You're specifically mentioning patients that are in pulseless electrical activity, meaning that there's electrical activity. What if they're in asystole? Well, if they're in asystole, we know their heart's not beating. So would you not want to put the monitor on early, make the decision of whether or not to do CPR based on that? I don't think so, and I'll tell you why. One, your interventions are still not going to be effective because if they go into asystole as a result of hypovolemia or obstructive shock or something like that, the best CPR isn't going to have any benefit if there's no blood to circulate or if there's an obstruction. But at some point, of course, you would have to do CPR if they're in asystole, right? Eventually, yeah, we would have to put on the monitor, make the determination. But also, and this is not meant to be nihilistic, but if they are in asystole, their chance of surviving is virtually zero. A trauma arrest patient that is in asystole upon your arrival has virtually a 0% chance of surviving. And of course, I'm not saying we should never not perform, or we should always not perform CPR, or we should never perform CPR. That's not the case. I'm saying just don't let it get in the way of doing the other things. And if you have a lot of people standing around, maybe the fire department's on scene and you can tell them to coordinate rotating through CPR, then let them do so. But what are our priorities? What should we focus on? We focus on our March algorithm. It just makes sense, right? But I did bring up that there are different algorithms for traumatic cardiac arrest, and here's one such algorithm. This is from Sidney Hims, and now if you've never heard of Sidney Hims, I'm sure they have a lot of YouTube videos. They are a very high-performing helicopter EMS service. They staff, I think, physician paramedic teams, and they are cutting edge and they're very high performing. And this is their protocol, and it's similar to what we've talked about before. If it's likely not a traumatic arrest, then just use standard ALS. Simultaneously address reversible causes, control external hemorrhage, control airway, bilateral decompression, fix cardiac tamponade. Now this is something that we can't fix. And if you suspect that the patient has it, then of course we got to get them somewhere that can fix it. We need more expertise. We don't have the equipment. Maybe the environment's better. They have a massive transfusion protocol. And then if they don't get a pulse after doing these things, then they consider termination of CPR. And I think that this is a good approach to all trauma arrests that don't have any obvious signs of death and that don't have injuries incompatible with life. Give them a chance, do all of the things that matter, and then decide, do we have a pulse now, do we not? So here is a bundled approach to traumatic cardiac arrest that is pretty much our new protocol. We treat hemorrhage, which means controlling the bleeding however you have to, binding the pelvis, straightening long bones, giving volume. And I mean, when we give volume, it's not let it flow in slowly. It's use an actual pressure bag and rapidly transfuse a liter. We perform bilateral decompression. We ventilate. We ventilate with a BVM and airway adjunct. We make sure our ventilations are going in by looking for waveform capnography. If the airway is not patent when we get up there, if they have massive facial anatomy distortion, we have a low threshold to perform a cric. We do all of these things either simultaneously or in quick succession. Your pit crew setup that we use for medical cardiac arrest will work. You just have to put someone in charge and assign roles. So what do we do if we get a pulse back? Well, if we get a pulse back, then we do the standard trauma stuff and we check everything. We may have to repeat procedures. We may have to tighten up tourniquets. We may have to re-decompress. We may have to re-secure the airway. We may have to give more volume to maintain a systolic of 90 for permissive hypotension. Of course, if they have a TBI, you might need a higher systolic. We want to avoid high PEEP, specifically in trauma. We provide post-intubation management. We maintain the hemorrhage control, and we aggressively treat hypothermia. And you can give TXA. Now, when I originally wrote our protocol, I sent it to Dr. Bernard at UK, had him review it, and he loved it. He said the only thing that he would add for post-arrest management would be give them TXA, just empirically give a gram if they went into arrest from trauma. Now, these are our protocols, and there are special considerations. If a patient is in arrest due to penetrating trauma, in general, they should be transported immediately. Now, of course, as I've said many times, this is not a always or a never event. There may be situations in which the patient died from penetrating trauma where it is not the most appropriate thing to transport them. But this is just a general rule. And if you don't transport a patient due to penetrating trauma, well, of course, you should have a low threshold to call med control and have a really good reason for not transporting them, because they can survive. Penetrating trauma patients can survive if they get to the OR quickly. And of course, if it's a pregnant female at or more than 24 weeks gestation, or you've got a palpable uterine fundus around or above the level of the umbilicus, then you transport them immediately. And of course, if it does not appear to be a traumatic cardiac arrest. And you will see in the protocol that it says to initiate chest compressions if personnel are available, and you prioritize the following. This is the following. These are the things that we have already talked about. You prioritize these things. Now, after you have done these things, you then check to see if a pulse. So basically, we're going to do these once. So imagine a situation where, if it's a penetrating trauma, then we're going to try to do everything while we're rapidly getting them to a trauma center, unless there are extenuating circumstances. If it is a blunt trauma arrest, we're going to do all of these things, and then if there's not a pulse present, then we put the monitor on. Okay? You don't have to put the monitor on immediately. Does that mean you can't put the monitor on immediately? No, it doesn't mean that you can't. It just means that it should not be a priority because it takes time and it takes personnel to do so. And in trauma arrest, time is critical. And doing these interventions as quickly and as effectively as possible is crucial. All right. So you apply the monitor and then you treat per the termination of resuscitation protocol. And currently, per the TOR protocol, if it is blunt trauma, and they're in a systole or a PEA less than 40, then you got to resuscitate them for a minimum of 20 minutes. So while you're resuscitating them for 20 minutes, you're still going to keep doing these things. You might need to re-decompress. You might need to further control hemorrhage, give more volume. And so I've had some people ask me the question of, well, what if they're like severely crushed, they have severe injuries, and you feel bad trying to resuscitate them? Well, I would rather feel bad for trying to resuscitate a patient than to feel bad for not resuscitating a patient and later thinking, what if I could have tried? Now, most protocols that I have looked at for pre-hospital trauma arrest do allow you to terminate if a pulse is not present when you arrive on scene, if it was not witnessed and it's due to blunt trauma. However, other protocols I've looked at require you to do these things listed on this protocol before you make the decision. And after you've done these things, you've reassessed, you've done them again, you made sure that you have checked all of the boxes, you're going to be close to 20 minutes. Does that mean you can't call med control earlier if you want to deviate from the protocol? No, it doesn't mean you can't call med control earlier. Now, if you communicate with med control, it might be beneficial to let them know all of the things that you have already done that were not effective. And the only thing meaningful that they could possibly do is pericardial centesis, which could be life-saving, or cracking the chest, which is not universally successful, and only physicians at a trauma center would do that. So those are just some considerations and some things to think about. Now, of course, what if you get a pulse back? Well, we've already talked about that. Generally, if we're going to ventilate the patient, we're going to keep the end tidal in a normal range. If we suspect a TBI, we're going to do standard, provide good brain care by targeting lower end tidal CO2, avoid high PEEP, and do all of these things. And we're also going to give a gram of TXA over 10 minutes. Now, I hope this protocol and I hope this training has cleared up some confusion, and I hope that it has answered a lot of questions that everyone has had. If not, please let me know. Text me, call me, email me. All right, thank you all.